Hello everyone and welcome to our module on alkylating agents. Let's start by reviewing a little bit of organic chemistry and let's talk about alkyl groups. Alkyl groups are molecular groups that have a formula CN2N+1, and there are many different subtypes of alkyl groups. For example, a methyl group, which is a CH3, is a type of alkyl group, so is an ethyl group, and so is a propyl group. So an alkylating agent is a drug that adds an alkyl group to a nucleotide base in DNA. Most commonly, the chemotherapy alkylating agents add an alkyl group to the N7 nitrogen of the base guanine. Guanine's chemical structure is shown at the bottom of the screen. Each of the atoms is numbered, and the N7 nitrogen is found right here. And this is the portion of the molecule that will have an alkyl group added to it by an alkylating drug. This will lead to cross-linking of DNA strands, and this will inhibit DNA replication and also cause DNA damage, and this will lead to cell death. And this is why these drugs are effective in malignancies. These are cell cycle non-specific chemotherapy agents. They can alkylate DNA and lead to cell death in cells that are in any portion of the cell cycle. So just to make this more clear, once again, here's the chemical structure of the base guanine. When guanine is placed in a nucleotide, that nucleotide is called guanosine. Over here on the right side of the screen are two guanine molecules that have been cross-linked by an alkylating agent. Note that an alkyl group is added to the N7 nitrogen of one guanine and also to another, and then they have been linked. So the alkylating agent will do this. It'll alkylate two guanine bases and link them together, and that's what leads to the DNA strand cross-linking. All the drugs that we're going to talk about in this video, even though they're used to treat cancer, you should be aware that they also can potentially cause cancer. In particular, they can cause therapy-related myeloid neoplasms, also known as TMNs. These are malignancies of the myeloid cells of the bone marrow, and they're caused by exposure to DNA-damaging agents, like the alkylating agents we'll talk about in this video. These myeloid cancers occur many years after exposure to one of these drugs, so often the patient is successfully treated, but then many years later they can develop one of these myeloid cancers. Usually it's acute myeloid leukemia. It's called TAML when it's therapy related, but some patients also develop myelodysplastic syndromes called TMDS. Anything that damages the DNA of cancer cells can also potentially damage the DNA of myeloid cells, leading to one of these secondary cancers. Alkylating agents that we'll talk about in this video are a common cause of these secondary myeloid neoplasms, but also the topoisomerase II inhibitors can do this. I talk about these in another video. And radiation therapy can do this as well. So in a board question of a patient who is exposed to an alkylating agent who presents for follow-up years later, you should be aware they're at risk for one of these cancers. At that point, they're unlikely to develop any acute side effect of the drug, but they're at risk for these therapy-related myeloid neoplasms. There are a number of different drugs that function as alkylating agents. I'll focus on the ones listed on the slide here in this module. So we'll begin with the nitrogen mustards, which are alkylating agents that have a structure similar to mustard gas. You may know that mustard gas was used for chemical warfare in World War I. Modified versions of the mustard gas molecule have led to the development of alkylating agents used for chemotherapy. And all of these drugs contain a central nitrogen and two chlorine atoms similar to the structure shown on the screen here. Mechlorethamine is the simplest of the nitrogen mustards. Cyclophosphamide is a very commonly used alkylating agent in this class. We'll talk about it in more detail in a few slides. Other nitrogen mustard alkylating agents include melphalan, chlorambucil, and then finally ifosfamide is actually a slightly different structure. It does not have a central nitrogen, but it still has two chlorine atoms, and it functions very similarly to all the nitrogen mustards. So let's focus on cyclophosphamide, which is one of the most commonly used drugs in this class. Cyclophosphamide is available in both intravenous and oral forms. It has good bioavailability when given orally, and for this reason, it's often used not as a chemotherapy drug for malignancy, but as a powerful immunosuppressant. In autoimmune diseases like some of the vasculitis syndromes and glomerular nephritis syndromes, the oral version of cyclophosphamide can be very effective to suppress the immune system. It's also used more often in the IV form in solid tumors and lymphomas and leukemias. Cyclophosphamide is a prodrug. It must be bioactivated by the liver. It is converted into a molecule called phosphoramide mustard, and importantly, it's metabolized by the liver P450 system, so co-administering cyclophosphamide with other drugs that affect the P450 system can be dangerous. Shown on the screen is the metabolic pathway by which cyclophosphamide becomes active. The liver P450 system converts cyclophosphamide into a structure called 4-hydroxycyclophosphamide. It then goes to the tissues where it's converted to a molecule called aldophosphamide and ultimately into phosphoramide mustard, which is the cytotoxic active form of the drug. It's also converted into a metabolite called acrolein, which we'll talk about in a minute. Acrolein is responsible for many of the side effects of cyclophosphamide. So because cyclophosphamide inhibits DNA replication, it can lead to myelosuppression by suppressing the replication of cells in the bone marrow. So patients on cyclophosphamide can develop a low white count, a low hematocrit, or low platelets. A unique and important side effect of this drug is that it can cause hemorrhagic cystitis. That metabolite acrolein, which I showed you on the last slide, is toxic to the bladder. This can lead to development of hemorrhagic cystitis, which presents as hematuria, possibly with dysuria. There's a lower risk if patients are well hydrated. In addition, there's a lower risk if a substance called mesna is co-administered with cyclophosphamide. This is the structure of mesna shown on the screen here. Mesna is sodium 2-mercaptoethene sulfonate, and mesna binds and inactivates acrolein in the urine and lowers the risk of hemorrhagic cystitis. Cyclophosphamide can also potentially cause SIADH. The drug has what's known as antidiuretic effects, which means it leads to the retention of water. This usually occurs with the IV dosing used as chemotherapy for malignancy. Since it triggers the kidneys to hold onto water, this can potentially cause hyponatremia, which can sometimes lead in severe cases to seizures. This problem is compounded by the fact that patients are usually hydrated while they're receiving cyclophosphamide to prevent the development of hemorrhagic cystitis. The mechanism of this is complex. There's evidence that there's more ADH release in the setting of cyclophosphamide and less renal response, and through all of these mechanisms, this can potentially lead to SIADH. Ifosfamide is an isomer of cyclophosphamide. It's used in some germ cell cancers and sarcomas, and just like cyclophosphamide, it can also potentially cause hemorrhagic cystitis. Two special side effects of ifosfamide are nephrotoxicity and encephalopathy. Ifosfamide is toxic to proximal tubular cells, so it can potentially cause the Fanconi syndrome. I talk about the Fanconi syndrome in the renal section. It results from loss of reabsorption in the proximal tubule. So patients who develop this syndrome can develop polyuria. They can lose electrolytes in the urine and develop hypokalemia and hypophosphatemia. They can also potentially develop a metabolic acidosis from loss of bicarb in the urine. And then finally, about a quarter or so of patients who are administered ifosfamide develop an encephalopathy, which often presents as confusion. The next group of alkylating agents are the nitrosoureas. These drugs get their name because they have a nitroso group, which is a nitrogen oxygen group, and they also have a urea moiety. Drugs in this class include carmastine, which is often called BCNU, an abbreviation of its chemical name, also lomustine, which is called CCNU, streptozotocin, and finally semustine. These drugs are bioactivated in the liver like cyclophosphamide, and one thing you always want to remember about these drugs, to remember what they do, is that they are highly lipid soluble and they easily cross the blood-brain barrier. For this reason, they are often used in the treatment of brain tumors, especially glioblastoma multiforme, and as we will see, many of their side effects are related to the central nervous system. These drugs can lead to myelosuppression. In rare cases, they have been reported to cause pulmonary fibrosis. They can also rarely lead to a chronic form of interstitial nephritis, which can cause renal failure. And then finally, because they are lipid soluble and can cross the blood-brain barrier, they can potentially cause encephalopathy and seizures. This usually doesn't happen with lower dosages, but sometimes very high dosages of BCNU are administered as part of a bone marrow transplant protocol, and in this setting, encephalopathy, seizures, and other central nervous system effects are more common. Our next alkylating agent is busulfan. This is its chemical structure shown on the screen here. Busulfan is often used for myeloablation in bone marrow transplant protocols. A single high dose of busulfan is administered, and it results in severe pancytopenia from bone marrow ablation, and this prepares the patient for a stem cell transplant. It's also sometimes used in the treatment of CML. Busulfan can cause myelosuppression. It can also potentially lead to skin changes, including hyperpigmentation. This occurs with other chemotherapy agents, including bleomycin, which has a very similar sounding name. And then finally, at high dosages, it can potentially cause seizures. There are many chemotherapy drugs that can potentially cause pulmonary toxicity, but busulfan is sort of famous for this. It was one of the first chemotherapy drugs described that could lead to pulmonary toxicity. Patients on busulfan can develop cough and dyspnea. This can progress to pulmonary fibrosis with ground glass opacities appearing on the CAT scan. This is a picture of ground glass opacities as can be seen in pulmonary fibrosis shown on the screen. Patients with pulmonary fibrosis can also develop restrictive PFTs and reduced DLCO. These are all signs of pulmonary fibrosis. and this can potentially occur in a small number of patients with severe busulfan pulmonary toxicity. I'll finish this module by mentioning two drugs that are part of commonly used protocols to treat Hodgkin lymphoma. The first one is dacarbazine. It's part of the ABVD protocol. ABVD stands for adriamycin, which is doxorubicin, a cytotoxic antibiotic. The B is for bleomycin, another cytotoxic antibiotic. The V is for vinblastine, which is a microtubule inhibitor. And finally, the D is for dacarbazine, which is an alkylating agent. This is its structure shown on the screen. And procarbazine is part of the MOP protocol, which can also be used for Hodgkin lymphoma. MOP stands for meclorethamine, the mustard agent we talked about earlier. O is for oncovin, which is another name for vincristine, a microtubule drug. The P is for procarbazine, and the second P is for prednisone, and procarbazine is another alkylating agent. This is its structure shown on the screen here. And that concludes our module on alkylating agents.